Hello, listeners. This is Jo Kitchen, the podcast host, and today I've got Leanna Luxton with me. So, hi, Leanna.
Hi. Nice to be here. Thank you.
I'm so pleased to be able to have this conversation, record it with you, because a while back I watched you do a TED talk and I was just in awe. You talked about how healthcare professionals don't always know best, and the impact this was then having on your team's approach to working with patients, and I just felt it was quite ahead of its time. And then I've also been aware of the project you've been doing with improving the support for people's mental health for stroke survivors. And I know a lot of us in healthcare have ideas about how we can make things better, but we don't always manage to make it happen. Now, the Health Foundation has this great graphic on the habits of an improver. And as a leader, I think I see you embodying those aspects, that positive mindset to generate ideas, to be able to influence others, and then also to take some calculated risks. And I know at the moment you're the Northampton Community Stroke Lead and Programme Manager for NHSE, and you also have your own company, Body Activation. So I'd be delighted if you could just tell us a little bit about your career so far and what's led you to want to improve the services you work in.
Wow, big question. Yeah, I am a physio by background and I have worked at the Royal London Hospital before I worked at Northampton General Hospital. I worked at the Royal London for over 7 years and I've been at Northampton General for over a decade now, specialised in stroke rehabilitation. I love stroke rehabilitation. You're meeting somebody really at their almost worst point when they've had that stroke. I said it in my TED talk, but a lot of our patients say, 1 minute they were fine and the next minute they're not. It's almost like that, an accident, just a complete shock. And that's their lowest point. And then really there are only real improvements. And that's how I view stroke rehabilitation. So yeah, I got into the community because I loved seeing people within their homes and in real life situations and how we really move people towards getting back to either the life they had or the life they want moving forward. So I love it. I have always been someone who's into service development. So I've always thought, we could move that, we could change that, we could do this slightly differently. I've always been one to just pilot. So my previous clinical specialist said I was always a sucker for a pilot because I do it without any funding. I just try something and then change it and be like, we haven't got enough staff to do this. So I learnt my lesson very quickly. But I've always wanted to improve. So I'm always testing and moving forward. And yeah, that's how I got into the NHSE pilot as a programme manager, because it was about embedding on top of our amazing service within Northampton, which is an integrated community stroke service. It always was set up that way to enhance their services by adding vocational rehab, peer support, and reablement care, and what we've termed conversational rehab. And that was an amazing 2-year project. We're now a substantive service, so we've been supported by our organisation to deliver that moving forwards. And my business in the background is around the expansion of those ideas, so really training other trusts and organisations in how we work, helping with service improvement, delivering online spaces and different online spaces to patients. So yeah, I've got a lot going on.
That is quite a lot going on, plenty to keep you busy there. I love that not only are you thinking about how to improve your own service, but then also how to be able to spread that to other services as well, and to teach other teams and bring them along with you. It was interesting when we first started thinking about this. You don't particularly, as far as I'm aware, use specific quality improvement methodology. or your background. You haven't been on, say, specific training, but the things that you talk about in piloting the new ideas, that is how in line with those sorts of values. So you able to tell us a little bit more about the conversational rehab and how you noticed there was maybe a need for that?
Yeah, so as I said, I've done a lot of pilot projects, and what I've learned is that when I start a project, how it ends is completely different. And so I would have an idea, but actually what actually works on the ground is actually something completely different. And the difference that made the difference was the patient voice. So I'd set up something and then I'd ask the patients whether they liked it. And then I'd get feedback and then I'd change it based on their feedback. So I thought, okay, why don't I flip this the other way and start with the insight? So as part of the project, we used an experience-led design approach. That's how I termed it, in that we interviewed over 100 patients about their general experience of the stroke pathway generally. So we weren't asking about specifics, just what their experience, and then we gathered themes from that. So the themes around their mental health were that they all, to some level, had some experience of trauma or anxiety or grief. So they had trauma around what happened to them, it being very sudden, anxiety about having another stroke or the future, and grief around what they had lost and their future, really. And that had an impact on their motivation and their resilience and their mindset for rehabilitation, and consequently had an impact on their purpose moving forward and who am I, really. And actually, what they asked for was that the people that were coming in every day in our team had the skills to be able to have those conversations, because what they noticed was our team would be coming in quite stressed, whether they'd been driving, doing lots of visits, or had a busy day, and they didn't want to put any more stress on them. They realized, they're doing such an amazing job, I don't want to stress them out with my problems. Or they would get shut down. So they would be, oh, don't cry, don't worry about that, we'll move on to your exercises and that will make you feel better. Or they could notice that the therapist or the person that was with them was starting to feel scared or stressed when they were telling them, and it didn't feel like a safe space. So what they wanted was those people to have the skills to be able to have those conversations, and especially because they felt these were normal reactions to a massive life event. They didn't actually feel like they were going crazy, in their words. They actually just felt like it was a normal response. So having an onward referral to something, other service that was to support their mental health, felt like almost it was, they weren't crazy. So you would then get oh, I don't need that. And they wouldn't access that support. And what would happen is our team would keep those people on for longer because you're worried about them. And so you don't want to refer them, but they're not really participating in their therapy. But then it would, you wouldn't have a good outcome. So actually, the kind of the ethos throughout the whole of the piloting phase was, we're going to challenge ourselves to put the patient at the centre. So within reason, what they asked for, we're going to try and do. And we had tried to recruit psychologists. We couldn't recruit psychologists. It wasn't an attractive role. I spoke to about 30 psychologists across the country, and it was because we were asking them to cover inpatients, rehab, community, VOC, with not as big a workforce as would be needed. So we had to pivot. And so we developed a program which is called conversational rehab, and that's where that came from. And it was a way for our team to have the skills to be able to provide in the moment support to that person around those specific issues in relation to their rehabilitation. So we're definitely not here to replace anybody or any psychologist roles. In fact, what it's done is it's really established in our team what the role of a psychologist would be, and how we move forward with that, with the funding that's available. But it gives those people, and I say people because we train band 3 staff, up to and rehab assistants, HCAs, nurses, physios, OT, speech therapists. We had one stroke consultant. We trained the whole MDT in it because it was a pilot to see kind of the acceptability and feasibility of doing that. And so in the end, we had 65 people across our pathway trained in a CPD UK accredited diploma in conversational rehab. And the beauty of conversational rehab is it's stroke specific, it's rehab focused, and it meets the needs of that specific problem. So yeah, we're really proud of it, and we're now looking at training other organizations across the country. And so yeah, it's an exciting project. I really want to test the feasibility, the acceptability, all those words, the idities, the validity, the reliability, all of those things in a service evaluation methodology, as well as in research methodology, to prove its effectiveness or not, really. Yeah.
Just sounds like such a massive unmet need that was being experienced by your group of patients. And I just love that you started off right at the beginning by asking them about their experience, and then bringing together what they were telling you to then think, well, this is what the project will be about. Because we tend to come of it with our own preconceived ideas or the latest jazzy bit of technology, rather than thinking and listening to our patients. What are they actually asking for? I also thought it was so insightful of them to be, despite their own difficulties, having experienced a stroke, to be noticing when maybe their healthcare professionals were coming in being stressed or not looking like they had the capability to deal when they're telling them something emotional. So that was really interesting there. Have you been able to record any impact or go back to ask your patients now that the conversational rehab is up and running? Have you been able to gather any feedback from patients on the project?
Yeah, so we did the insight at the beginning, and then we did it at the end, and we continue to do it. So there were many different mediums that we used to gather the insight. And I'd always say, whenever I get to talk about the project, my biggest kind of take-home message is for project managers, or whatever your title is, to relax when in the patient's insight, because being able to say 80% of our patients say, this many of our patients say this isn't their experience, and this is why I'm moving the project forward in this way, is a safe space, because there's not many commissioners or trust leaders who can argue with that, really. So I did that throughout the project, and I used surveys. So when we got the themes in relation to the insight, so they were around transitions. So patients always talked about the transitions between services being clunky, or mental health support, or communication. So, my therapist on the ward doesn't know my therapist on the community. Those were the themes. We were able to make commitments. So all of those themes became our pathway commitments. And underneath each of the commitments, we have statements. So under transitions, it might be, my transition across the pathway was smooth and clear, whatever the wording is. And it would say agree and strongly disagree. And then we'd have our survey. So then we'd be able to not only survey our patients, but we'd interviewed them again, and we set up patient forums. So as we were really rocking with the pilot, we would have between 20 and sometimes 30 patients on a forum. And how we ran our forums were They were topic based. So if we had a topic such as vocational rehab, that would be the topic of the month. Those patients that were interested and wanted to feedback on their journey of returning to work would come to that forum. And then we talk about the service provision we had, we get feedback. And it was much like this, a safe space conversation. And it really allowed us to have constant insight throughout the process and feedback from patients who were at the beginning of their journey. They could be 5 years post-stroke. If they had any cognitive or speech deficits, we'd do one-to-ones with them. We'd use talking mats. We were always challenging ourselves to gather the insights in different ways. And so what we were able to find is, or gather, were our KPIs. So things like, from doing this project, especially with the conversational rehab, we were able to improve our responsiveness. So people were getting that kind of well-being support within 48 hours in comparison to a year-long waiting list. The sessions were, there was a higher dose of sessions, so they were getting seen every time they had a session. There was some type of integrated support. We also learned that our length of stay reduced for those patients. So whereas they would, on average, have stayed with us if they were accessing anything, any psychological support, or level 3, as we would call it, for 120 days, that went down to on average 70 days. So we were able to use those KPIs to be able to show its effectiveness. But then in terms of our experiential data, so I termed that our KEIs, so our key experiential indicators. And then we were able to use case studies, service data. So like I said, 80% of our patients felt our transitions were better, whereas 10% at the beginning of the pilot. So we were able to then communicate to our commissioners or trust leaders in ways they understood. It wasn't just John said it was good, which is, or you'd have a quote from a patient at the end of all of this outcome measures data. It was actually just as important. And I think one of the biggest things was getting our forum to talk to our trust leaders. So we had a forum where our chief exec and our commissioner came, and so they were able, because the patients were very used to talking about their story, they were able to articulate their story in an amazing way. And what we were able to show is, yes, within our service currently, if you go through our service currently, you'll have a good outcome. Our service was good before the pilot. But if you add on having integrated emotional support, helping people to return to work, they get to meet a stroke thriver through our peer support service as soon as they touch base with our team, and the care is integrated into their rehab. These are the outcomes, and then that's your choice. And they wanted to choose that enhanced service, and we were lucky enough to be supported to deliver that.
Sounds like a really powerful set of data, that.
Yeah.
So to have your KPIs, the patient's experiences of your service, and then to have facilitated a session with your stroke, did you call them thrivers?
Yes.
Yes, your stroke.
Because we have a peer support service, so we would, again, from the insight, our patients said that they wanted to meet someone who'd had a stroke earlier. They wouldn't meet them until they were 6 months or a year down the line. And so we employed stroke thrivers, and that's what they want to be called, into our service at a band 3 level. And so again, it's the challenge of proving the worth of that service. So I would say for all rehab models, that is a challenge. The quantifiable benefits of having a lived experience within your service is pretty hard to quantify. But we were able to potentially, how we did it was show how clinical hours could be saved, because these peer support workers aren't delivering rehabilitation, but they can do things like secondary prevention advice, provision of information, onboard into our online hub, 6-month reviews. So things that as a therapist you may not be using your hands-on skills to do, but they can be done by a peer support worker in a different way, and you can save money in inverted commas that way.
Yeah, and you had a quite incredible statistic about your length of stay within the service.
Mm.
What did it reduce from and to?
So with our level 3 patients, so those with ongoing persistent mental health issues would stay on our team on average 120 days, and patients who didn't, so our level 1 and 2 patients, would stay on average 70 days. And what we were able to do, minus a few outliers, and that was in relation to their age. So if they were younger, because of how they're returning back to work, etc., kind of taking that out of the equation, the length of stay on our team became on average the same for everybody, which was amazing. And I think it's because the framework that conversational rehab is built on is actually it really is the TED Talk. It's my experience of being in a teaching hospital where everything is research. If it's not in the research, it doesn't happen. And my experience was there were patients where, yeah, they don't have any flickers in their arm for 6 months, but then they're progressing better than patients who have a lot on paper going for them. And I really wanted to understand why that was. And the things that, for me, through my experience of seeing patients, was their physical health in general. So how they look after themselves, their self-care, do they sleep, do they eat correctly, etc. And then their environment, so how set up is their home for recovery, really. Their social network, so who's around them, and their relationships, have they got supportive relationships or not? Their mindset, so if someone really is compelled to do something, willing to do something, and able to do it, they will progress because they have that mindset for rehabilitation. And their identity, so how in conflict they were now with who they were before and who they are now. And so all of those things together, which, there's others, are the keys to recovery. We're able to have our therapists assess the patients in relation to those. And then, like I said in my TED Talk, create their compelling reason for recovery. So what is it that's going to drive that person to their end outcome, whatever that is, And so all of these frameworks help to keep us safe. We have a common language between ourselves. We have a standardized way to assess our patients. We've stratified our patients into the 5 C's. So whether they're in crisis, whether they're in cope, whether they're coasting, whether they're conquering or creating their goals. And suddenly you have this ability to say, this person's in crisis, these are the areas that are contributing to that. And we have a toolkit to be able to deal with that. And then when it's out of our scope of practice, we're then able to refer on. So we're getting to the point with our patients quicker. We've got the plan because we know, everyone knows what that North Star is. And if the person cannot create a compelling outcome, or they can't create or visualize what they would want their life to look like, then that's part of the journey. Because where are you all going to? And when's the end? When will that person feel happy and secure? And so I found within my own work, when I worked that way and looked at it more holistically, like, these are the things that are working in their favor. They've got a really good mindset. Their emotional state's really stable. They've got a good social network. They may not have the best physical health, but we're able to work with that. Then you have a better plan. And that's why I think has helped our team to kind of focus down and be a lot more efficient with what we've got. And because we've got a lot of things to refer on to, a lot of teams refer out and don't get that feedback in. Whereas we don't necessarily have to refer out because our whole MDT is so wide and varied that we can just do it all in house.
That sounds great. And like as a therapy team, an MDT team, you've all gone through the same training. So you also have that sort of North Star in mind, so that when you're going through with the patients, you can be really clear on the ways that they're hoping to progress. To me, it just sounds like what we might think of being additional extras to a therapy service are
Yeah.
actually becoming a real core component that are essential to getting someone in the right state of mind to be able to engage with rehab and to be able to make progress. Did you have any challenges along the way or any critiques of what you were proposed and implementing?
I mean, yeah. You're that might be an understatement, challenges. I
It
think
was a digging question.
yeah, what was it? So I've had to I've had a lot of challenges in thinking that this is a replacement for psychologists within the service. So I want to make it crystal clear that this is not a replacement of any type of role. What we have here is, as therapists, we own rehabilitation. So this is how we are going to get the best out of our patients for rehabilitation. For me, it's a way for us to redefine rehabilitation. I have a key ethos that without someone in the right mindset and emotional state, a lot of what you're doing is going in one ear and out the other. If you're meeting someone who's in crisis and you're unable to, and they're highly anxious and they're not in their body, they're not steady, which is what we say. We've got to get people steady. And so the things that we're doing around breathing, meditation, visualization are not owned by anyone. They are just steadying techniques. Once someone's nervous system has calmed down, their cortisol levels are down, they're able to then have the best environment for neuroplasticity, the best environment for learning, and then we can get people ready. That's the next step, getting ready for rehab around thinking, getting yourself into the mindset of setting your compelling outcome. And then once someone's in the green and they're ready, they're at a point where they're self-directing their rehabilitation. So you've given them the knowledge, the skills, and the resource to be able to self-direct their ongoing rehabilitation so they can live this life beyond stroke, which is what we're talking about here. So all of those things, if instead of thinking of it, and I don't really think about it as mental health support, I really think of it as emotional and mindset support, and it's helping people overcome things around physical sticking points. So you see that, like unable to get out of the chair, can't leave their house, and emotional stress points, and you'll see it like they're in a worry loop, they're worrying about this, that, and the other, and how they can feel steady enough to participate. So where the challenge has been, people thinking that it is a psychological model that is assessing people and giving them diagnoses around their mental health condition, and it's nothing of the sort. I think as well, the challenges has been from the teams that are getting trained. This isn't, why am I doing this? I'm a physio, I do physio exercises, and I give them the exercises and I leave, and I do the work with them. And so actually expanding to think that this is a fundamental part has been a challenge, which is why we've set the whole pathway underneath it. So having, this is how we assess, this is how we talk to each other about the patients, has helped people understand, because it gives you a way to talk about the most complex patients. Whenever someone's in a crisis point and it's a really complex person and they've got lots of different things going on, if I can say they're in crisis, these are the keys that are affected, this is the resource I'm trying it for this many weeks, this is the outcome I'm hoping for, then you feel safe. And so there's some safety in that, which has helped them a lot. And I think the challenge as well has been time. You know, people say don't have time to do a lot of things, don't have time to come out to do training, don't have time to take away from my rehabilitation, I don't have time. But actually, I always say it's really good. My gran has this saying, you go slow to go fast. And actually setting the person up at the start of their rehabilitation, contracting with them about how they're going to work, knowing what your North Star is around that outcome at the beginning, and obviously your outcome can change, means that you do get to the plan and you get to the point quicker with people. So yeah, those have been, I'd say, the main challenges. But we've been able to overcome them. I mean, this is a 3-year project ongoing. You know, the team are still going through the change. You lose people, you have turnover of staff, you have staff you haven't done the training, integrating with staff that have done the training. So it's how you manage all of that as well.
Yeah, certainly a lot to do. Are there any aspects of this that you're like particularly proud of or pleased with how it's gone?
I think the thing that has been the most pleasing to me is hearing the staff talk in MDTs in this way and use the framework to help their clinical reasoning. I know it sounds small, but it's they've really embraced this way of working. I've been really proud of the feedback from the patients. You know, we have our online community called George's Place, and it's again came from the insight that patients said they didn't have a safe space to meet other people, and especially people that are in their area. So on George's Place, you have not only a library of information from different sources, you have podcasts, you have people can do posts, they can private message each other, but you can also join remote groups. So they have our own remote groups, but then they have mindful art and yoga, etc. And so we've had patients on there and staff, etc. And one of the patients actually made our first logo for the hub. And the story is that she was seeing one of our band fours, and she was an artist, and she couldn't go into her art room. And you know, she was doing really well with her upper limb, but she just wouldn't go near her art. And so the rehab practitioner band four who had done the training started using the conversational rehab toolkit to be able to dig a little deeper as to what was underneath that block. And she'd actually forgotten that her father had had a stroke at the same age, and it had been quite traumatic for her as a child. So actually sharing that with her, they were able to do some steadying techniques around that. And then she went into her art room, and she said on the forums that she would never have gone into her art room had she not had that conversation, and the rehab practitioner hadn't held that safe space for her. And so she made our first logo, which was like two people holding hands walking into the distance. And we're really proud of that, because again, it's not your normal level of staff member who to be doing those detailed conversations. The person feeling so safe psychologically, not only to have that with that person, but then share it on a forum, and then the outcome of having our logo like that. So yeah, there are lots of things. I'm proud of the whole project. I'm proud of my team for coming along the journey when I was just kind of doing it as we go along. The trust and faith they had to change their service based off of an idea and of the patient insight was huge. So yeah, proud of them all, proud of the patients, proud of everything and what we've got moving forward in terms of testing it and hopefully sharing it as widely as we can.
Absolutely. And that, I think that shows the power of stories as well, because
Mm.
to hear about that patient and the things she managed to overcome with the support, that really is just, I can picture her there and the difference that's made for her life. So while we're here, I was wondering if you've got any advice for other leaders or aspiring leaders, because not only did you have to think of like see the need and the gaps in your service, but you also had to bring your team along with you. And so, yeah, are there any things you've learned that you'd like to share?
Yeah, let me think. I think communication has could be the biggest thing that I've learned, improved, could still improve more of. I don't think you can over communicate when there's a change happening, especially a massive change. Um, and I think in the beginning, I I did what you normally, the stakeholder mapping, who needs to be involved, what meetings need to have, what governance needs to be in place underneath it. But I think having one-to-one conversations with people, I have band 3 and 4 meetings. I have middle leaders meetings for my band 5s and 6s. I have senior meetings for my 7s, because everyone at different levels have different drivers and barriers. And I'm now leading a team of up to 80. I can't have all of these conversations one-on-one. So I think just finding different ways to communicate your message, being open to feedback and challenge, but also not getting sucked in to every single issue that comes up, because you are the safe place for your project. If you're easily rocked, the project isn't going to go anywhere. So you do need a clear vision, but be open and communicate that vision, communicate along the way, but be open to that feedback. So that, I think that would be my biggest learning, but also sharing point. And like I've said before, insight, insight, insight. Gathering as much experience, insight you can. And just like I did for the patients, I did that for the staff as well. So we interviewed all the staff around what it was like to work within the service, and their experience of treating patients, really. So I was lucky enough to do that because I had the time. I was taken out, I was a project manager for that project. I definitely understand that team leaders who are trying to make incremental change as they're going along without external funding or support, that would be really challenging. But you don't have to do it on that scale or in that way.
Absolutely. And you started off with small pilot projects, didn't you? And from that, you tested and things grew over time. Well, thank you ever so much for joining me today. I have really enjoyed hearing all about your project, and I will be certainly remembering your grand's words of go slow to go fast. That's going to stick with me.
Thank you. Thank you for having me.